So we are going to do the respiratory failure and respiratory acidosis station from critical care. So post-operative day 2 following right hemicolectomy, complaining of dyspnea and confusion. It's a patient. On examination, BP is 110/70, heart rate is 110, respiratory rate is 10 per minute. So it's a bit bradypnea. Respiratory rate is low. Suppose the oxygen saturate is 65%. Drug chart shows morphine overdose. Oh my god. How CO2 is transported in the blood? So bicarbonate 70% in the form of carbonic acid HCO3, H2CO3, and then carboxyhemoglobin 20% between the CO2 and proteins are peptides, most of which the globin portion of HB, and dissolved CO2 is 10%. So this combined from the total CO2 transportation. Chloride shift is the diffusion of chloride into the red blood cells to maintain cellular balance as bicarbonate ion moves out. So this is chloride shift. So here you can see the reaction between CO2 and waters in the presence of carbonic anhydrase enzymes. So it gives you bicarbonate ion and hydrogen ion. So hydrogen will bind to hemoglobin, and here the bicarbonate ion is pushed outward, and for neutrality, electric neutrality, chloride will go in. So this is chloride shift. So write down the equation. Examiner will give you a pen and paper. So H2O and CO2 combines to form H2CO3. This is carbonic acid. In the presence of carbonic anhydrase, it will give in the RBC, it will give you H plus ion, carbonic bicarbonate ion. So bicarbonate ion will diffuse out. This binds to HB, this diffuses into the RBC, which is chloride shift. And examiner will give you the an ABG which shows decreased pH, increased CO2 level, normal bicarbonate. What is your diagnosis? So this is respiratory acidosis but uncompensated. If this uncompensated respiratory acidosis, what is the cause of respiratory acidosis in this patient? So this is morphine overdose. Morphine works through mu receptors in the medulla and pons, and it gives pain relief, suppresses the pain. So there is these mu receptors in the respiratory center as well, so it also depresses the respiratory centers in the post medulla. So this causes bradypnea, low respiratory rate, and so will cause the accumulation of CO2. So why is still no metabolite compensation? So we know that kidneys takes time to react. Respiratory compensation takes 30 minutes to 2 hours. Like the respiratory compensation is quick, whereas the kidney or renal compensation is slow, which takes about 3 to 5 days. So why is bicarbonate normal? This is the same reason, because the initial response, the response to acute respiratory acidosis is 2 steps. So initial response is cellular buffering that occurs over minutes to hours. Cellular buffering elevates plasma bicarbonate only slightly, approximately 1 milliequivalent for each 10 millimeter of Hg of CO2 increase. So the second step is renal compensation that occurs over 3 to 5 days. With renal compensation, renal excretion of carbonic acid is increased and bicarbonate reabsorption is increased. So bicarbonate will go out, and carbonic side will go out, and renal bicarbonate reabsorption will be increased into the plasma. So it will take time. That's why it's leaking. The bicarbonate is normal still. So name respiratory center. So central respiratory center in the pons and medulla, and then we have the peripheral respiratory receptors in the aortic body and the carotid body. So we know that common carotid artery splits into internal and external carotid artery, and there is a bulb. So here these chemoreceptors, as well as in the aortic arch as well, we have these chemoreceptors. What type of respiratory failure is this? A respiratory failure, this is type 2 respiratory failure. Why? because we have two types of respiratory failures. One is type 1 and one is type 2. So in type 1 we have only decreased O2. The CO2 is normal. So so type 1 is ventilation perfusion mismatch. Ventilation perfusion mismatch. So the volume of air flowing in and out of the lungs is not matched with the flow of blood to the lung. So this occurs in pneumonia, bronchitis, pulmonary embolism, and pneumothorax. Type 2 is caused by inadequate alveolar ventilation, both O2 and CO2. In type 2 respiratory failure, we have decreased O2 and decreased CO2. So both are affected. So both and 2. So this is type 2. So both CO2 and oxygen is affected, defined as the buildup of carbon dioxide levels that has been generated by the body but cannot be eliminated. The underlying causes include increased airway resistance, COPD, asthma, suffocation, reduced breathing effect, drug effects, brainstem lesion, extreme obesity, a decrease in the area of the lung available for gas exchange such as chronic bronchitis, neuromuscular problems, and deformed kyphoscoliosis, chest shape problems. What is the physiological response to hypercarbia? Elevation of CO2 leads to central acidosis, which stimulates central chemoreceptors and lead to increased respiratory rate in order to blow off extra CO2. How morphine act? Morphine binds to mu receptors on the respiratory center, causing respiratory depression. ABG, what do you think of partial pressure of O2? So partial pressure of O2 is normal. Only we have CO2 buildup. So why partial pressure of O2 is in normal range? Because FiO2 is 0.6, which is equal to 60%. We have the so here we have the saturation about 65%. Why I2U for this patient is required? Because this is morphine overdose, and morphine overdose can lead to serious depression completely and respiratory center depression. So he may needs mechanical ventilation. So and if you are reversing it through naloxone, so it will need cardiac monitoring as well. How will you manage this patient? Call for help from from my consultant and ITU registrar. ABC, manage according to CRIS protocol, ensure adequate oxygenation by humidified O2, ensure adequate ventilation, either non-invasive or invasive, intubation and invasive, respiratory support or CPAP, management of underlying cause, stop morphine, and you can give naloxone as antidote. 0.2 0.4 to 2 milligram IV initially and repeat 2 to 3 minutes, and if no response you can go up to a maximum of 10 milligram. What are the side effects of naloxone? Nausea, vomiting, sweating, tachycardia, abdominal cramps, pulmonary edema, and cardiac arrest. So you have to admit this patient in ITU because the patient may need multi-organ mechanical support. So for respiratory you can go for mechanical ventilation, intubation, and mechanical ventilation, and for this you can have hemodialysis or hemofiltration, and cardiac you need continuous monitoring and inotropic support, neurological and tractional pressure monitoring. So this was all about this morphine overdose and respiratory failure. Thank you.